My first periods, the worst nightmare. In the midnight of my 12 years birthday, I felt something strange. The vagina started bleeding. Don't be surprised. To me, it was a nightmare. Though I was not asleep, I thought that very soon I would wake up and that the blood should stop, but it didn't stop. I cried and cried, asking for help. Mom, please come and help. She quickly came to my room. When I showed her, she just laughed at me. Don't be afraid. You're grown up. This is what we call menstruation. As I have never been at school, as I have never got out of a house, even a single day, to have a chat with my peers, as my mother assumed that a blind girl like me didn't need that kind of knowledge, of course, I should not have had any idea about menstruation. In a blink of an eye, my mother brought me one of her oldest clothes. She cut it into big parts. My daughter, please use this so that you don't make your bed sheets dirty. Remember, I didn't have any skills about sexual reproductive health. I was not taught by anybody to do any kind of self-care. Guess the time my mother came to help to support me to change. 10 hours after. What a bad smell. What a lot of pain. How embarrassed I was. I will never and ever forget about that. Because this is the worst experience I've ever had. But finally, my life has changed. I escaped that terrible situation. Miraculously, I got the support and went to school. I got different skills. I know what menstrual hygiene is and its use. I can make my own money. I can have access to water, buy sanitary pads and soap. But don't assume that this experience only happened to me. Menstrual health for girls and women with disabilities, especially those who are poor and those with severe disabilities, it's a big challenge. We find girls and women with intellectual disability on the street. We even find them in menstrual period. They look weird and dirty, but who cares? We just laugh at them and move on. Those who think that they are merciful, they ask God to stop menstruation for all ladies with intellectual disability. But that's not a solution. They're also human beings. Instead of that, let's stand, join hands, put our voices together and advocate for the removal of all barriers which hinder girls and women with various disabilities to fully access information and products of their menstrual health.
Dumelang, Absheni, bon dia, bonjour, good afternoon. Welcome to the Menstrual Hygiene Health Day webinar. My name is Lerato Lahamurulane, a proud member of the African Youth and Adolescent Network in the East and the Southern Africa. And on behalf of UNFPA East and Southern Africa and the African Coalition, I am honored to be your master of ceremonies for today's special event. We are thrilled to have you here to celebrate 10 years of Menstrual Hygiene Day and to be part of our global movement that is making a groundbreaking impact for people who menstruate on the African continent through their life cycle. Today's webinar, it delves into the different cycles of menstruation, including perimenopause and menopause, and its impact in the lives of girls, women, and middle-aged women, including those menstruating in the framework of the universal health coverage. Before we dive into the festivities, I have a few housekeeping announcements to make. For your comfort, interpretation in French and Portuguese is available during the webinar. At the bottom of the screen, you will get the interpretation button. If you are posting about this event on social media, please do tag us on these handles at UNFPA SRO, at MHDay28. You can even see them at the bottom now. You can also use the hashtag period friendly world and hashtag MHDay2024 to follow the conversation. Now, please use the chats to share any questions or comments that you may have. We will begin with the opening remarks from Chino Ogbonna, the Deputy Regional Director of UNFPA East and Southern African Region. Welcome, Ms. Ogbonna.
Honorable Minister Pitso Lesuana, the Minister of Gender, Youth and Social Development, Lesotho, Africa Coalition on Menstrual Health Membership and Leadership, distinguished guests, colleagues and friends, good morning, good afternoon, depending on where you're joining us from. Wow, 10 years. On Tuesday, the 28th of May, 2024, the world will celebrate the 10th anniversary of Menstrual Hygiene Day. On this day, over the past 9 years, we have united to amplify the importance of menstrual health as a human right, required to ensure bodily autonomy, agency, empowerment, and equitable participation of women, girls, and all people who menstruate across all spheres of life. Our collective voices as government, private sector, development partners, United Nations system, including UNFPA, donors, young people, women, and people who menstruate have continued to make inroads, and UNFPA joins to applaud our collective successes. Countries are moving forward towards integrated responses to menstrual health, and national menstrual health policies are being introduced in many countries in our region, including in Kenya, in Rwanda, and in South Africa. In addition, civil society, the private sector, and individuals continue to champion innovative strategies to meet menstrual health needs. Under the theme of the 2024 Menstrual Hygiene Day, Together for a #period-friendly world, the world is taking stock of progress that has been made in ensuring that discrimination, stigma, and taboos surrounding menstruation are a thing of the past. And to further heed the call to accelerate actions in creating a world where every girl, young and adult woman, as well as people who menstruate, can access products, period education, and period-friendly infrastructure as may be required. Why? This is because while we are more than 8 billion strong and counting, millions around the world are still prevented from reaching their full potential just because they menstruate. The Africa Coalition for Menstrual Health, established in 2018, is an example of what collective efforts can achieve, and UNFPA is definitely proud to partner with the coalition. Distinguished participants, colleagues, friends, our work is not done. Far from it. Millions of women and girls of reproductive age in Africa look up to us to help close the gaps in equitable access to necessary education, information, products, and services needed to ensure healthy menstruation and to manage other forms of uterine bleeding in a dignified, empowering, safe, and healthy manner throughout their life course. The cost of inaction is significant and too much is at stake if we do not do this, considering that poor menstrual health and hygiene outcomes do undermine the rights of women, girls, and people who menstruate, with impact on their bodily autonomy, their agency, their empowerment, and their participation in socioeconomic transformation-related opportunities. Beyond the 2024 Menstrual Hygiene Day, we need to effectively use the unique and critical global, continental, regional, and national milestones to amplify the importance of inclusion of menstrual health as a fundamental human right and as a core component of sexual and reproductive health and rights. Our collective and decisive actions will promote and protect rights and human dignity for present as well as future generations. These rights are central to taking forward the 6 transition and investment pathways which have multiplier effects towards achieving the SDGs. So as we take stock today and as we pulse check our collective journey, the webinar today ahead of us and ahead of the 2024 Menstrual Hygiene Day is convened to also emphasize the urgency of coordinating far-reaching actions. This can only be possible if we adopt a life cycle-based approach from pre-menarche to menopause. Colleagues and friends, please be assured that UNFPA, the United Nations Population Fund, remains committed to our resolve and our partnership with you as we collectively ensure menstrual health is both a significant determinant as well as an outcome of sexual reproductive health and rights, from biological through to socioeconomic transformation. In this regard, allow me to offer 5 areas for consideration as we go forward and as we strive towards a #period-friendly world. The first one, we need to deepen the multi-sectoral approach to menstrual health where all stakeholders address menstrual health in an integrated and coordinated manner while adopting the life course approach. 2, we need to address affordability issues that constrain access to products and leave millions behind. We have evidence on how subsidies and local social entrepreneurs can lower production and delivery costs without compromising on quality. For example, removing taxes on menstrual health products, as has been done in Kenya, Lesotho, Ethiopia, Rwanda, and Zimbabwe, has had significant impact. We need to fully unlock the power of innovative financing for sexual reproductive health and rights, including menstrual health. The third one, innovative solutions and programs in menstrual health need to be bolstered if we are going to reach the scale desired. We need to responsibly, and I repeat, responsibly tap into the digital technology space and also use non-tech solutions in this regard. The fourth one, our actions need to be guided by evidence, including research around high-impact interventions and possible integration pathways for menstrual health management. Evidence and data will also help us understand the remaining gaps and the challenges that still persist across the life cycle. And the fifth and last one, we now know that we must understand the impact of humanitarian crises, be they climate or conflict-induced disasters, and the relationship with the ability of women, girls, and all people who menstruate to manage their menstrual health in a safe and dignified manner. In the face of crisis, our agility to ensure access to quality products and services is key. Colleagues and friends, so the question is, what are we going to do about all of this? And how many more areas of actions do we need to take forward? I know that these will emerge from the webinar today, And I am hopeful that a period-friendly world will become a reality in our generation, and then we can pass it on to future generations. I therefore look forward to listening to the diverse voices and expert panels lined up today that will inform the next set of actions in our collective journey and contributions towards the SDGs, ICPD Programme of Action, and aspirations of Africa Agenda 2063, the Africa we want. I thank you for your attention.
Indeed, Ms. Ogna, the question is, what are we going to do about it? Thank you very much for that. I would like to invite the Honorable Minister Pitso Leswana, the Minister of Gender, Youth and Social Development from Lesotho, to provide us with a keynote address.
Good morning to you all. I wish to recognize the presence of UNFPA East and Southern Africa Regional Director, the representatives from ESA countries, distinguished guests, young people invited in the important event, senior officials, and all protocol observed. Ladies and gentlemen, others and distinguished guests, it is indeed a pleasure for me to participate in this important webinar to discuss issues on menstrual health. As a minister responsible, among other things, for gender equality, youth empowerment and social welfare, issues of universal access to menstrual health products are very close to my heart. I believe that universal access to menstrual health products is a step towards gender equality, youth empowerment, and a pathway to support the marginalized. We know that for many of our countries, Lesotho included, young girls, especially from those poor families and rural settings, do not always have access to menstrual health products. We also know that menstruation remains shrouded in stigma and myth. This creates unnecessary shame on a natural phenomenon that otherwise demonstrates a sign of health and vitality. As part of my portfolio, I actively engage with the community, particularly young people. It deeply saddens me to witness the challenges faced by our youth, notably young girls from disadvantaged backgrounds who experience menstrual poverty. They lack access to sanitary towels, which adversely affects their education, mental and physical health, and overall development. I've met many girls who have discontinued school because of menstrual poverty. I sometimes wonder how many dreams have been deferred because of denial of a relatively cheap commodity that can make a difference to the education, health, and overall development of a girl child. In our journey to seek solutions to this challenge, the Kingdom, in collaboration with UNFPA Country Office, undertook a national study to understand the menstrual health landscape in the country. The findings are disheartening. The study revealed that many girls, especially those from impoverished backgrounds, cannot afford sanitary towels. Consequently, 1 in 10 girls miss, on average, 3 days of school each month due to menstruation. In some cases, girls discontinue school. This situation, coupled with stigmatization, not only impacts their mental health, but also their physical well-being. The government of Lesotho directed the quantification and costing of a national program. We are working closely with the UNFPA Country Office to establish the national cost of providing these products for free. We will use these findings of the quantification and costing to mobilize resources to address this crisis. Investments in menstrual health yields multiple benefits, including poverty reduction, stronger economies, and improved overall well-being. I cannot wait any longer to ensure that girls from disadvantaged households in Lesotho have menstrual towels so that they do not miss school, and ultimately ensuring that all the people who menstruate in the country have free access to sanitary towels to unblock developmental opportunities that are otherwise prohibited by menstruation poverty. Madam UNFPA Regional Director, ladies and gentlemen and others, on behalf of the government of Lesotho, I extend an invitation to UNFPA to continue this journey with us. Let us jointly support coordination efforts and resource mobilization to provide essential menstrual health products to those who need them most. In closing, I invite my colleagues across the region to prioritize menstrual health as an investment in the well-being, dignity, and empowerment of all individuals. Let us pledge to normalize conversations about menstruation. Let us stand united, break the silence, and ensure that every girl and woman has the right to manage her period with dignity. Remember, menstrual hygiene matters for health, education, and empowerment. Let us embark on this journey together. I thank you and wish you a successful webinar that will make a difference to the girls and women. Khotso Pula Nana.
Khotso ene re a leboga, Honorable Minister Letswana. Our first session for today is a conversation with menstrual health influencers within the framework of universal health coverage. This session is going to be moderated by Dr. Shela Mokhaila Mokhabudi, who is from the Africa Coalition on Menstrual Health. She will be joined by Candice Shira, a social influencer, Sanele Lukele, lecturer at the School of Nursing at the University of Western Cape, and Birgit Kogot, who is the Kenyan Programs Manager at Days for Girls International. With that said, over to you, Dr. Sheila.
Thank you so much, MC Morutani, and thank you so much for all the speakers that have been put already. We will be going through the bios for our speakers today, and in no particular order. We do have Candice Shira, social influencer, recognized as the Minister of Menstruation. And also, she's also a distinguished academic, an author, a public speaker. Good morning, everyone, and thank you so much, MC Morulani, and regards to all the speakers that have been through already, and introducing you to our esteemed speakers for today. We have our first speaker as Ms. Candice Shira, the social influencer, also recognized as the Minister of Menstruation, and she's a distinguished academic, an author, a public speaker, and a social entrepreneur. Renowned for her exemplary leadership of the acclaimed NGO, Curate, she has garnered a prestigious award for her outstanding contribution to menstrual education. With a passion for social impact, Candice has achieved a remarkable success in her advocacy efforts, solidifying her position as a respected figure in both academic and entrepreneurial circles. She is available on the handles at Candice Shira, and Ms. Candice Shira, you are welcome to the platform. The audience is all yours, ma'am.
Thank you for having me. Ministerial greetings to everyone. This is such a lovely occasion to be a part of. I am Candice Chirwa, a Minister of Menstruation and a passionate menstrual health activist. And I always start my journey around my menstrual health around my first period story when I started my period at the age of 10. It was a traumatic experience. I felt alone, isolated, and 18 years later, being the Minister of Menstruation, I am very passionate about educating people and providing empowerment. So I am really excited for the conversations that we'll be having here today. And more than anything, I'm really excited to be building a period-friendly world with all of the speakers from today's session.
Thank you so much, Ms. Candice Chirwa. And what motivated your advocacy journey linked to the menstrual health? Could you tell us more about you, the Minister of Menstruation?
Yeah, so I started my period at the age of 10, and when I had my first period, it was a very scary time. No one had the conversation with me about sexual reproductive health. No one had the conversation with me about puberty and what to expect. And I think what really sort of cemented my period being seen as a negative thing was just being told that no one should know when I'm menstruating. And I came across research when I was 21 about period poverty and the impact that period poverty has on the girl child, but most importantly, when a girl child has their first period, how they feel it's such a scary time for them. So I felt something needed to change. And that's where Curate came about, as a way to be a vehicle for change, to create menstrual health workshops for people to feel empowered, encouraged, but also to learn about menstrual health as a natural biological function. So for me, I had a very negative first period experience, but I thought that the cycle needed to change. There's the silence and the taboo needed to be changed and eradicated. So that's where my passion came from.
Oh yes, changing the narrative and moving it towards, the positive direction that is. And based on your numerous engagements, what are the key menstruation needs of girls and women in Africa, as well as opportunities to address that?
I feel that education within menstrual health is often a missing component when it comes to the empowerment of women and girls. When we're not having empowering and engaging conversations about a natural biological function, people who menstruate often feel that they need to feel isolated. They feel that they shouldn't speak about their period conditions, whether it is any period symptoms associated with your mental and behavioral, or anything associated with pain management. It often becomes an isolating time. So I think there's this missing component that we often tend to skip out of in the discussions of eradicating period poverty, and it's the inclusion of education, not only just targeted towards African girls and women, but also including the boy child and men in these conversations. Because when we think about building a period-friendly world, it has to incorporate everyone in this situation. And I think as a menstrual health activist, as the Minister of Menstruation, my platform really is about just encouraging people to speak openly around it. Because as we know, when we don't speak openly about periods, and people don't know the right methods and the right ways to manage their period, and therefore what happens is that people will often say, well, no one's spoken to me about this conversation. Let me just rather use X, Y, and Z unhygienic materials. Or no one has spoken to me about period conditions, so I'm going to assume that my period pain is normal, even though it's debilitating. So for me, as a Minister of Menstruation, it's about speaking openly and confidently about these things, to say nothing bad will happen to you when you speak openly about menstrual health. Nothing bad will happen to you when you say the word vagina. Nothing bad will happen to you when you say menstrual blood, because this is a natural biological function.
Thank you so much, Minister. You have put it just perfectly, because the conversation around menstruation has to start as early as 9. The education around it, the destigmatization, it's got to be looked at as any other subject. That has to be, it has to be has changed. It's got to be done differently. Thank you so much, and your work is to raise our heads for you, because you are doing a very wonderful work out there. Thank you so much, Ms. Chirwa.
Thank you for having me.
And for the next, our next speaker is Ms. Sanele Lukele, Ms. Sanele Lukhele, and can you kindly flash having a profile for me, kindly? Ms. Sanele Lukhele is a lecturer at the School of Nursing at the University of Western Cape. She holds a master's degree in midwifery and neonatal nursing science. Her areas of interest are maternal child and neonatal health, adolescent reproductive health, as well as indigenous knowledge systems. Sanele is a passionate midwife who always advocates for midwifery-led care for all low-risk women. She has made it her mission to educate those within her reach about midwifery-led care. In 2019, she was awarded the Houghton Primus Excellence Award in the health category. Her collaborative, people-centered nature has allowed her to build a strong professional relationship throughout her career. As a testament to this, she was appointed on the Nursing Now Challenge Midwives in Focus Steering Committee in 2022. In 2023, Sanele was one of 6 youngest nurses who was chosen by the Nursing Now Challenge to form part of this delegation that attended the World Health Assembly in Switzerland, Geneva. Her most recent invitation to serve has come from the Society of Midwives of South Africa, where she serves on the executive committee as a social media correspondent. Ms. Sanele Lukhele, you are welcome. The floor is yours, ma'am. The audience is all awaiting what we have to bring forth today. Thank you. The floor is yours.
Thank you so much, Dr. Sheila. I'll be speaking about menstrual health and hygiene from a reproductive perspective, and also from the perspective of a midwife, of course. So, menstrual hygiene management has 4 requisites. Firstly, there has to be availability of a clean menstrual management material to aid in the absorption or collection of blood. Secondly, the girl and woman should be able to change the collection material in a private space as often as she needs to throughout the menstrual period. Furthermore, there has to be clean water and soap available for her so that she can bath as she requires. And also, there has to be access to facilities to dispose of any used material that she might have used during her menstrual period. These are the type of absorbents which are currently available. They include reusable and washable cloth pads, commercial sanitary pads, tampons, reusable tampons, menstrual cups, and pads made from other natural materials such as bamboo and banana fiber. Studies have shown that reusable pads are strongly correlated with urinary tract infections. Girls and women who use reusable menstrual pads are twice as likely to present with a positive urine culture. A systematic review which assessed usage, leakage, accessibility, safety, and availability of menstrual cups found that menstrual cups were a cost-effective alternative to pads and tampons. The incidence of leakage with menstrual cups was the same, and in some cases, less than the conventional pads that are being used. And also, 70% of women in resource-constrained areas reported willingness to continue using the menstrual cup. While the onset of menstruation is a vital part of female physiological development, it also marks the beginning of an adolescent girl's reproductive life. Early menarche is defined as menarche prior to 12 years of age. Early menarche is linked to earlier initiation of sexual intercourse. At just 12 years of age, girls do not have enough information about the menstrual cycle and what it means. Furthermore, they are unable to make informed decisions about protecting themselves from sexually transmitted infections and to prevent pregnancy. Attempts from the National Department of Health in South Africa to build adolescent and youth-friendly facilities to offer sexual and reproductive health services have been largely unsuccessful, as these facilities remained underutilized by the youth and underfunded by government. Adolescents are also reluctant to use these services because they don't want to be labeled as sexually active. Scholars recommend that attempts to address adolescent pregnancy should focus on aspects such as sensitizing parents and communities to the importance of appropriate open communication about sexuality and reproductive healthcare services. Gender equality programs should also be put in place, and also there should be adequately trained healthcare workers specifically trained on the range of contemporary contraceptives available. The importance of dual protection can also not be emphasized. While there has been much debate about the undesired side effects of pharmacological methods of contraception amongst women, contraception remains the most reliable method to prevent unwanted pregnancies and ensure adequate child spacing for women of childbearing age. There are different types of contraceptive methods. The choice of contraception method should be made in conjunction with a nurse, midwife, or doctor. Choice of contraception is not just about what the woman prefers, but also takes into consideration any comorbidities that she may have. There are also myths and misconceptions that contribute towards the type of contraceptive a woman may choose. For instance, some women believe that monthly menstruation is necessary to relieve the body of menstrual blood buildup. Midwives and nurses should be at the forefront of dismantling misinformation by educating women about different contraceptive methods, how they work, and how they interrupt the ovarian cycle. Combined oral contraceptives give women a sense of control as they decide when to take the contraceptive and the choice of when menstruation will happen. This provides them with assurance that they are not pregnant. Hormonal long-acting contraceptives are associated with menstrual suppression. This provides relief for women who suffer from very painful periods, as well as heavy menstrual bleeding. For women who have given birth, there is the choice of for women who have given birth and are exclusively breastfeeding, they can make use of the lactation amenorrhea method. However, this method works if the woman is exclusively breastfeeding and hasn't seen her period. If the woman stops exclusively breastfeeding or her period resumes, then the method is no longer reliable. The woman is then advised to move on to another method. When the woman transitions from the lactation amenorrhea method, she is advised to either use a non-hormonal method of contraception or a progesterone-only method of contraception. These methods don't interfere with breast milk supply for the baby. Now, I would like us to consider infertility. The World Health Organization defines infertility as a disease of the male and female reproductive system, marked by the inability to conceive after 1 year of regular, unprotected intercourse. Female factor accounts for 35% to 50% of infertility cases. The Center for Disease Control contributes for infertility to the following causes, all of which have to do with the ovarian cycle: defective ovulation, defective transport of fertilized ovum or sperm, defective implantation of the fertilized ovum. In South Africa, 1 in 6 couples experience infertility. However, policymakers are yet to define infertility as a disease. This means that this has led to services that are inaccessible, scarcely available, and also cost an exuberant amount of money for the couples. Infertility seems to be the stepchild of sexual and reproductive health services, with only 2 hospitals in South Africa offering the full spectrum of fertility treatments, and then another 2 that are private public partnerships. This shows that there isn't enough investment in infertility care for couples who so desperately need this service. Therefore, I would like to make a call for governments, policymakers, as well as funders to invest in infertility care for couples who so desperately need this service. Thank you so much.
Thank you so much, Mr. Nele Lukele, for this insightful, very insightful information and the collaboration of what we are on today, and the fact that, sexual and reproductive health forms a very major part of menstruation. Basically, that's where everything else is. And with regards to that, more recently, menstruation is being addressed from the broader sexual and reproductive health aspect. So as well as on the gender equality issues. So as a midwife, please share your insights on how menstruation is linked with other health concerns while integrating menstrual health within SRHR and universal health coverage. So if you can just probe into a little bit of mental health, prevention of infections such as urinary tract infections, risk of STIs, etc. In your response, you will be able to address everything. That includes the health, the fertility, infertility, and contraception, as it was presented.
Okay, so as I've already alluded in my presentation, it's very important that young women are provided with menstrual cups. These are reusable, they are affordable, and also they have shown that they are less likely to cause infection, such as urinary tract infections. Menstrual cups are a once-off purchase, or most of the time it's donors that give out menstrual cups at schools and at other places where young girls are. The use of menstrual cups helps to make sure that girls do not become susceptible to urinary tract infections. So if there's one takeaway, it's for us to really invest as countries in the use of menstrual cups. Research has shown that in the beginning, the girl takes some time to familiarize herself to the use of menstrual cups, but with peer support, women really, really warm up to the menstrual cups, and they've shown satisfaction and acceptability for the end user.
Oh, thank you so much, Ms. Kelly. And just in closing, do you find that there is much that is being done, particularly when it comes to school health? How much of menstrual hygiene and the reproductive processes are actually being discussed at the educational level? How much of it actually goes into that as part of the school health program?
Okay. So school health programs are programs that are run by primary healthcare nurses in the schools, in primary schools, most of the time. There are school health nurses that are employed there. It is the responsibility of the school health nurses to teach the primary school going kids about sexual health, and because now the age of menarche is getting lower and lower. So we need to empower young girls to get ready for their first period, because like the previous speaker said, they're probably not going to get this information at home. So it's very important for them, for the nurse or midwife that's working in the school health setting, to really prepare young girls for that moment. Also, some provinces and some governments are providing pads, sanitary pads for girls so that they don't miss school. So schools are handing out sanitary pads to girls to make sure that they are ready and that they don't miss any school days when they have their menstrual period.
Well, thank you so much, Ms. Bukele. And we truly appreciate your all the efforts and all the work that went into this presentation. And we surely believe that Africa is richer, it's more richer with information today after what you shared with us. Thank you so much.
Thank you.
Okay, and yes, so without any further ado, we would like to introduce and welcome Ms. Bridget Kugat from Kenya Programs Manager. That's from Kenya, and she's the manager at Days for Girls International. Ms. Bridget is a programs and policy professional with a wealth of experience working with non-governmental organizations and country governments. She has worked with several development projects, and her main career focus has been on public policy projects and public-private partnerships, and also gender mainstreaming. She's a member of the East Africa Institute of Public Policy and the African Women Entrepreneurship Program, AWEP. Her top 4 career highlights are nominee for Bill and Melinda Gates Award, top 120 under 40 most influential youth in sexual and reproductive health in Africa. She was also a first runner-up for Advocate of the Year Award by Africa Youth Awards, and she was a nominee for Top 35 Under 35 Awards Kenya on Human Rights category, and recognition by AMREF Kenya for active participation in key advocacy initiatives. This is an initiative that ensures the voice of youth and adolescents in Kenya is represented in policy decision making. We welcome you, Ms. Bridget. The floor is yours. The audience is awaiting what you have to share with us today. Thank you, Bridget.
Thank you so much. First of all, I think I'd like to be proud of our country. I would want to say that I think we are the cradle of menstrual equity, not only in Africa, but globally. So allow me to share my field experiences for the last decade, just highlighting the key progress that we've made and the lessons all of us can learn as we approach 2030 and beyond. Before I dwell into the key progress, I'd like to highlight that despite menstrual health being a key component into the health sector, it has actually been neglected, which is ironical because I believe that menstrual health is the start of everything in terms of the overall well-being of all people who menstruate. But despite such challenges, like I have mentioned, Kenya has made significant progress. And the first one that I'd like to highlight is the policy advancement. Kenya has been at the forefront, and in terms of having a standalone menstrual health policy in place. It's not intertwined anywhere. Kenya was very particular, the CSO network, the NGO network, and the government was very particular that we needed a standalone menstrual health policy. And to add on that, we also have a strategy that clearly guides the implementation of that policy. We've also had tax exemptions in terms of the menstrual health products. And we've even gone ahead and even gotten tax exemption in terms of fabrics that are used for reusable menstrual products. So I feel like that has been one of the greatest advancement, because if we want to talk about menstrual equity, we have to ask ourselves how, when, and what resources need to be there so that we actualize this agenda. Another significant progress that has been made is in terms of creation of awareness and education. When that Kenyan team was looking at the policy, there was data that most girls did not have any information prior their menstruation in terms of the products available and what to expect, like will their bodies change when that time gets there. So I think that what has happened is we've had multi-sectoral collaborations between NGOs, grassroots organizations, and government, and we've also had multilaterals coming in, and we've had campaigns and educational programs specific to menstrual health. So what has this done? We have been able to reduce stigma and promoted open conversations. In Kenya, we are now able to openly talk about menstruation, even with key influencers in the social media stream, where young people are found can now get information, they can air their issues, and they can even get medical help from there, including mental health services. It has also helped other challenges that come up, like the previous speaker has spoken about other emerging issues in the menstrual health space. For example, the issues on infertility, endometriosis. It has given that door for people to start speaking about it, which were matters that previously would be stigmatized in the society. Another great progress in Kenya is access to menstrual products. What stakeholders have now been doing is to advocate for choice, product choice. Previously, what we all knew was the disposable product. And most of the time, people would just know of one or two companies. And what would happen? It would introduce myths. Some young people and women are also being barred from using certain products, such as the washable products, because of cultural barriers. A quick example is from my community, whereby you do not, your blood should not, go to the ground. Like, you cannot wash your blood off. So it deterred women from using other alternative products. But now with the access of products such as menstrual cups, washable cups, disposable ones, working hand in hand with the increased information that I talked about, we are able to have these products everywhere, including the local centers. Another critical key progress that we've made is integration of menstrual health into the healthcare services. One of the things that the Kenyan government has been eyeing is incorporation of the community healthcare promoters, to up to the last person in the village. And menstrual health is one of the components that they talk about. So with menstrual health being integrated into healthcare, it has helped increase impact. Another key progress has been research and data collection. When the policy was being formulated, there was, issues in terms of getting relevant data so that we know, like, what is the baseline and where do we want to go. So over time, governments in conjunctions with INGOs have come together and started to work on research on menstrual health that is now providing data to provide with the current policies and also programs. We've also seen NGOs now coming in, not only doing programmatic work, but including M&D in their activities. So with that, they are able to now come up with case studies and actually tell people authoritatively, like what is happening and how can we handle menstrual health programs and activities to make sure that we are having greater impact and we are not replicating roles or wasting resources. So what are the lessons learned as a person and as people in the menstrual health programming here in Kenya? We've learned of the importance of multi-sectoral collaboration, more so in the healthcare, education, and in the private sector. It is important for all of us to work together so that with the little resources that we have, we are able to create more impact. We've also learned the need for cultural sensitive approaches to address stigma and taboos. We often mention about stigma being among the main source of menstrual equity not being achieved. But for us, we took a step back and said, could it be that probably our language is not culturally sensitive? And sometimes not all culture is bad. It's just about like how we convey. What is our language when you go to the field? What is the language in the field? What is the language in the books to that particular community? Another lesson learned was the value of community-based initiative and local leadership in driving change. Who are the caretakers of this information that we want to pass? Who are the caretakers of these policies we want to pass? In terms of public participation, who is this person we want to target? For us here in the call, probably for us, it would be easy to take in the agenda of menstrual equity. But for the people that we want to reach, we have to make sure that we use community-based initiatives to get the buy-in. So in conclusion, we have had significant progress. We still have ongoing efforts and innovative approaches, and we should build on what I've just discussed as the key progress as we move toward 2030 and beyond. And maybe just to note, technology should not just be, in terms of products. Innovation should not just be in terms of technology. We should start thinking about innovation in terms of program design and business models. Thank you.
Thank you so much, Ms. Bridget. And we truly appreciate the efforts and all the work that has been put through for this for the presentation. And on this, instead, we would like to thank all our speakers for the great work that they have done in ensuring that the message goes across and is being received the way it was actually prepared with so much effort. After that being said, I would like to take us back to the MC to actually run off with the rest of the program. Thank you so much. You've been the greatest of the audience. Over to you, Ms. Murulan.
Raleboga Tatenda, thank you to all of our speakers from the first session. That was a very meaningful and timeless conversation. We will now go to an artistic performance by a South African poet, playwright, and social activist, Napo Mushene, titled Africa. Enjoy.
There's a silent tongue of thunder before the rollout of the rain. From the silence of our skies, what song, what psalms, what mystery among these blades of grass has the good Lord made? She has made my mother, my sister, my daughter, my warrior, my aunt, my teacher, my priestess, my twin, my grandmother, my lover, my healer, my world. God has made you a phenomenal being, the very essence of this lifetime. There are young girls who use culture as their home and the world as their mirror. Young girls who refuse to fall from their childhood like leaves that weep from a tree. Their hungry throats wait for pure milk from the breasts of earth. And their sisters who hit and hit the streets like lightning to tell stories that even our hearts will never write. They put on their shoes, embrace their crowns, walk to survive the journey. She has made my mother, my sister, my daughter, my warrior, my aunt, my teacher, my priestess, my twin, my grandmother, my lover, my healer, my world. God has made us phenomenal beings, the very essence of this lifetime. We have the power to defy the forces that perpetuate harm and to realize a world where every woman and girl is free to chart her own future.
Indeed, we do have the power. Welcome back from that brilliant poem. It is my great pleasure to introduce the next session on the transition from menstruation to perimenopause and menopause, the social and health implications for middle-aged women. For this session, I would like to call upon the moderator, Badia de Pethes, to introduce herself and her fellow speakers. Over to you, Badia.
Good morning, everybody. Can you see me? Good morning, everyone. Thank you so much for staying behind because we need to move from the bleeding to something else. And that's something else, you won't believe it. I know that having menstruation is not easy for young girls and young women, but imagine if I tell you that there is something coming, that is even worse. I don't want to scare you. It's part of life, right? But yet, it is something that we need to understand a little bit more. And a woman that is prepared know how to handle her future, right? So I'm Bidia Dupert. I work with you on FPA. Most of the people online know me as the condomized lady. So I do condom in all of their forms. And but today I won't be talking about condoms. I'll be talking about women. And they said middle age, I'm not so sure. Because you will see from our discussion today that menopause actually, because of environmental factors, can be initiated before the average age of 51 that was classified by WHO to be the medium age of menopause. Actually, women can have menopause, start menopause at 38, which was my case. Thank God I had my kids already. And it could be at 40, at 45. The thing about menopause is that it kicked in where you are at the best of your life. You know, you are like more mature, you're more responsible, you're financially secured, and you have a much higher position. And so many depending on you at workplace, but also at home. And yet come this thing in woman's life. I often said that if I believe in a reincarnation, I would ask God to come back as a man, because men, we go through a lot. So I would like to see my two panelists today, if it is possible by Isaro to have them together next to me, because this is gonna be a conversation for women and men actually, working with UNFPA and people who have also joined from other agencies. I would like to see Susie, Sue, and April together with me. Is it possible to also see the second panelist? Because we're gonna, exactly. So we are three women and they know. So I'm not going to introduce them. I want them. It's going to be conversation. So, Sue, why don't you tell me who you are? Tell everybody who you are.
Pidia, thank you so much for having me. You know, I'm a woman with an experience of menopause. I'm from Southern Africa. I've lived across Africa, several different countries. My background, I'm a biologist, a geneticist by training, but I work in the area of advocacy and governance for the last 30 years. In the last 8 or 10 years, I've started working on menopause awareness and response. I'll stop there for now.
Wonderful. And I'm going to turn to April. April, who are you? Why you're here? What is your link with menopause?
Thank you so much. I co-founded Medovia, which is an organization here in the States that supports menopause in the workplace primarily. And in full disclosure, I worked with Bridget with Days for Girls International for about 10 years. So I come with a menstrual health and sexual reproductive health background and have just moved into the menopause space here in the States.
So we have Africa represented and the US. Next time, we're going to make sure to also bring in Asia and Latin America and Europe. And that thing, we're going to take it to the global so that we can have even more and more time to discuss this. So one question that I had when I was reading your bio, and also UNFPA has created a space where we really start talking about sexual health. And in that, there is a place for menopause. We even recently conducted a survey for all UNFPA women, and we got over 200 people who answered the survey, and the answers to it was unbelievable, unbelievable. I'm not gonna talk about it. I'm gonna start by the people in the audience. If you do have your computer in front of you, can you go to the chat and give me one word or two words that comes into your mind when you hear the word menopause? I thought about one word, but then when I was looking into the menopause survey, I'm like, there is no way. Okay, everybody, I believe that Sue and April, you can see what people are saying. Hot flashes, senior moment. I don't know what is that. Old. Okay. Hot flashes. No more baby. End of pleasure. I mean, dry skin, flush, end of period. So these are things that people. What is menopause, Sue? If you think of menopause as symptoms, both of you, you've studied this. Is this the answer, or what can you tell about the menopause symptom that women and girls go through? I say girls, okay, maybe not girls. 38 is not a girl anymore. But please tell me, and who's concerned? Does it start and never end? Or is it a period in a woman's life and then it stopped like menstruation? Over to you. Either one.
Oh, thank you, Bidia. Thank you so much. Thank you, Bidia. Thank you so much. You know, I think it is a normal stage in a woman's life, and that we have to be clear about. But, you know, I was so amazed when I was listening to the section on menstrual health. Everything that was said about, you know, the onset of your period, you could actually scratch out, you know, menstruation and put menopause. You know, it is a time when there's a lot of vibrancy in a woman's life, right? Because we know that 3/4 of the women who go through menopause experience symptoms, and 1/4 of those experience really difficult symptoms. These symptoms, I know everybody talks about hot flashes. And in fact, a lot of people think that hot flashes is menopause. By the way, Bidia, I don't call them hot flashes. I call them 1,000 red hot daggers. That is my name for, and a dagger is like a little spear. It's like a little knife, a sharp, you know, a weapon that they use here in Southern Africa. So I call it 1,000 red hot daggers. So you've got the physical symptoms, dry skin and so on that people talk about, but you've got the physiological symptoms. People don't talk a lot about the physiological symptoms. So you may actually have your cholesterol levels go up, your insulin levels get all out of whack. You may have your internal organs being messed around because of inflammation. So those are the physiological symptoms. Then you also have the cognitive symptoms, the brain fog. I can't remember where I put my keys. What was the word that I was about to say? And it takes you extra 2 seconds to remember. So you've got those physical, the physiological, but also some of the cognitive symptoms. Put together, this can be a time that can really disconvolulate a woman's world. But 1/4 of the women go through menopause without significant symptoms at all. So the
Like
thing
you
to
once.
remember is that it's just completely different from one woman to the next.
So I don't know, April, do you think there are differences with race?
Absolutely. That's a very good question. And you noted earlier that the average age to reach menopause is 51, but really with other ethnic groups, we see that much earlier. So menopause, which by the way is the ceasing of menstruation, it's a one-day event. And that's really misunderstood as well. I'll get to that in just a moment, but with other ethnic groups, we're seeing women reach menopause in their late 40s, for example. So if we look at perimenopause, which is really where most of the symptoms that Sue just mentioned begin to present, if you back into perimenopause, we're beginning to experience those symptoms in our early 30s and early 40s, depending on each woman, really. It's not just your ethnic group. It has to do with genetics, your family history. If my mother went through menopause early on, I'm most likely going to go through early menopause. So there are a lot of factors that come into play here.
Wonderful. So, but I did read a study in the US called the SWAN study. And you could see the obviously, African Americans seem to experience menopause earlier, and the symptoms are much stronger in this group of population than it is with the white women. And I don't know about the Latin American, for instance, or the European.
True.
Did anybody study all of these differences in populations? And why are Black people, Black American, I don't know whether Africa also has studies showing that Black women, as compared to European, etc., Caucasian, seems to be having more. I'm listening to any study you had come across and reviewed to answer these questions.
Sue, do you want to take that one?
I'll go first. Yeah, thank you. Yes, you're right. The studies that you've seen that reference the US population, we've got similar studies, but not many here in Africa. There was a study that was undertaken by actually one of the hosts who appeared, one of the guests that I had on my podcast, in South Africa. She's based in South Africa, and she did, a study across, sub-Saharan Africa, and has seen a very similar trend that brown women tend to go, a little bit earlier, and they have more intense symptoms. But I think also there's a sociological aspect to it, not just a racial, that if you think of it, in any community, you have what you could call a Southern community. Those that have got a lower income rate, higher stress levels are having to. Those women, tend to have a tougher time with their symptoms. So I think there's something that starts to suggest that globally, I think women who are brown skin tend to be to have more stress, to live in more southern constituencies, socio-economically, and that could be the link, over and above just the racial factor. April, yeah.
Yeah, the SWAN study is the only study here in the States that I'm familiar with that specifically looked at that. Thank you, Sue, for addressing studies and research in Africa. Sue took the words out of my mouth. There's a lot of factors that come into play. It's not just genetics. It's not just race. You have to look at the socioeconomic status of a woman as well. You have to look at the complete lifestyle, what access she has to resources and healthcare to manage those symptoms. For example, does she have access to hormone replacement therapy? If not, she's going to suffer those symptoms in a more severe manner. Cancer treatments, if someone's not able to take cancer or estrogen rather because of cancer treatment, she has a more severe symptom management as well. So really it's like an onion that you have to peel back. It's not just one answer for everyone across the board. Every woman is unique and you really have to look at it case by case.
Okay, I'm going to challenge you here because I'm an epidemiologist. So I tend to read science all the time. But I absolutely did read that the Asian women, because of their diet and the high level of soy and soy grain and all of that, tend to have less, they don't even have menopause. Menopausal symptom. I
You're
don't
right
know
in that.
whether
You're
you
right in
look
that.
at the
Asian women have
woman.
less symptoms than other
But is it
ethnic
the Asian in
groups.
Americas? Because I don't want to talk about the one in Asia because their diet would be so rich on that. But I guess that they would turn to more westernized diet when they get to the US and second, third generation. Does it still apply?
You have to look at the complete lifestyle of someone. When you look at let's take an individual that, let's take myself, for example. Okay, I'll use myself as an example. If I went through early menopause. I have access to HRT. I take HRT because I want that estrogen in my body. I'm at greater risk of osteoporosis, for example, because I went through early menopause. I also look at my diet, I look at supplements, I look at exercise as a part of that longevity and that health span so that I have less symptoms, I live longer. And I think that's the case with everyone. You can't just look at it as a single solution. So I'm glad that you actually brought that up. In the case of someone that can't take HRT, lifestyle management is important as well. Diet and nutrition, exercise, having the low impact weight bearing exercise is important for that bone health. So I'm going to come back to what I said earlier in that it's not just one answer. It's not one thing, and you have to look at the full picture of someone's health.
So that's interesting.
Vidya,
I have a lot of
if
people
I
now
could come in there.
sorry, come in.
I was going to say, the thing with menopause is that it is so complex and that in many aspects, the research is still quite contradictory, right? It's an early science in many ways. It's quite interesting what you said about Asian women not having symptoms. And yet, if you look at, I think it's population review, you can Google it. It has a map, a global map that shows you the age of menopause, the average age by which women, enter, into the menopause transition. Some of the earliest, the lightest color green on that map is India. So on the one hand, we're saying that, their symptoms are like, but they seem to be going into menopause earlier than any other part, of the world. So it's quite mixed, the research out there. But I wanted to mention one other study, Vidya, just really quickly. Opinion worked together with Vodafone to do a study in 5 different countries to look at the impact of menopause in the workplace. And only South Africa was the African country that was included in the study. And it showed that South African women had the highest percentage of those who are being impacted severely, those who are hiding their symptoms at work and so on. So there is something to be said about, Africa and brown-skinned women having a tougher time from research.
Okay, let me ask you something that I also heard. I didn't read, but I heard that people who are fat have a less thin are less likely to have menopausal symptom. Is it true?
I haven't heard that.
You have not heard that. So let me take you to menopause.
I've seen research that says that
you've heard that?
Women who are larger, who tend to be more obese, seem to struggle more with their menopause symptoms.
So it's the opposite.
Well,
about
can I go back
menopause?
to that for just a moment, though, Bindi, to point something out here? I think it comes back to looking at the full picture as well, because if we're talking about an individual that has additional weight, we're at higher risk for other things, diabetes, for example. And so that could come into play with menopause symptoms as well. And so it really goes back to, Sue, what you were saying just a moment ago. There's not enough research on menopause. We need more funding and we need more research so that we can really understand this. Is there a correlation between weight and symptoms? Is it a higher risk of diabetes and higher levels of blood sugar? We don't know. We don't know.
There is a lot we still don't know, but why is that? I mean, we've been created at the same time as men, and men already even have a Viagra to keep it increasing the sex life and drive. And we are talking about something that is so natural, and we're still talking about something that is understudied. Why is that? What's going on? What can we do about this? We even can talk about blood coming from a vagina, which is normally stigmatized, and we make it more normal we make menopause a taboo. Something is wrong, and I don't understand. What is it? What is it?
Why? If we come back to patriarchy, we really come back to patriarchy and prioritizing issues that are important and that affect men, and deprioritizing the issues that affect women. And we then look at internalized, patriarchy, where even women in leadership positions will not pay attention to these issues, because even a woman in leadership is a product of her upbringing. And so, we tend to reinforce, don't we, the inequities unless we are particularly careful to observe the issues of women. So, I mean, if you think about it, according to the European Menopause and Andropause Society, in 2021, there was something like 657 million women between the ages of 49 and 59, right, in the workplace, right? And most of those, 50% of those will be in the workplace. Many of them are now in decision-making positions. Now, I work very closely with companies and organizations, raising awareness and helping them to become menopause friendly. So the question is, if we have so many women in leadership of their organization, why do we still have menopause impacts not addressed in the workplace? It comes back to the issue of patriarchy and women not feeling that they can actually voice these issues and actually reinforcing the marginalization of their own sisters. So we have some work to do.
April?
We have a lot of work to do. I also think that there's a lot of fear. If we're speaking specifically about the workplace and women in senior leadership roles, there's a lot of silence and shame that's associated with menopause because it hasn't been discussed. We don't talk about it from generation to generation. But there's also a lot of fear of losing your jobs. I was just in a large organization this week doing a training, and they had mass layoffs in the IT department. And we were talking about menopause and raising awareness. And one woman said to me, who's in her 50s, I'm not going to say anything because it's this age group that is losing their jobs right now. And if I disclose to my manager that I'm having difficulty concentrating, for example, I might get fired. So there's still a lot of fear in the workplace of speaking up. And I've worked so hard to get in this position. I'm not going to lose it. So I'm just gonna button up, and I'm not going to say anything, and I'm going to try to manage through it. It's happening all over the place.
This is just a terrible. And so,
but there are signs of change, Bidia.
Yes.
Yeah, we are seeing signs of change. You know, I had a guest on my podcast who said exactly what you said, April. She's an African woman who is living in Canada, and she's in the financial services sector. And so she appeared on that episode as anonymous. She wouldn't give her name because she was afraid that if she disclosed that she sometimes suffers from brain fog momentarily, that she might lose her job. But then on the other hand, I am in Zimbabwe at the moment at the invitation of one of the larger corporations here. Their chairman reached out to me and said, you know, I was having a meeting with a senior executive in one of the entities in our holding, group, and I noticed that she was suffering badly from hot flashes. Would you come and work with the different organizations in our group and make sure that we're giving our women the support that they need? So, and this was a man who had become conscientized from an episode of my podcast called For Men, and he really took up the interest and got, has become an advocate. So there is, there's hope when we can have these kind of encounters.
It's education and awareness, right? We have to raise awareness and educate so that everyone understands what menopause is, what the symptoms are, how it affects women in all aspects of life, so that we can take action, right? Awareness is first.
Right. Yes.
So we have about 5 minutes to go, and we need to take this conversation to another session, okay? Because there is so much that we need to unpack, and we just start scratching the surface. But this is a workplace environment, UNFPA, and the people also listening in and working in places. Some of them have even men as supervisors. Like you were just mentioning, they don't understand because we women ourselves don't understand, or we don't talk about it. So nobody really fully understands. What can be done at the workplace policy? What do you see? What did you read? Have you gotten good examples of organizations that manage to acknowledge that women can go through this phase and they're still competent? They just needed to be given some flexibility to doing their work. What can we learn as the UN and the partners online so that we can start thinking in terms of solution for ourselves, not only for others, us? What can you tell us?
Do you want me to jump in, Sue?
Yeah, I'll come after you.
Yes. I'll give a few examples, and then Sue, I want you to have time on the floor too here. There are several things. I think first we need to look at culture of inclusivity, making sure that it's not just diversity, which is important, but that we look at creating cultures that respect, value, and include everyone, regardless of their background, their ethnicity, or their life stage or age, frankly. We need training and education, as we just mentioned, that awareness, that education, evidence-based information, correct information, so that we break down those myths and shatter the stigma. We need policies and practices that are put in place that protect women in the workplace. We need to look at working environment and engagement, modifications, accommodations, and these can be simple and they can be temporary. They don't have to be long-term. Can we give her access to temperature control in the workplace? Can we make sure that we have period products like we talked about earlier in our discussion here? Can we give her time to take breaks for cold water, for example? Opportunities to change her clothes if she's having hot flashes every 20 minutes. So there are modifications and accommodations that can be made to allow her to thrive in the workplace. Sue, there's only a few more minutes left, so I'm going to let you have the floor.
Thank you. Everything that April said, plus, Bidia, what has been really crazy for me to recognize is that the entities that are leading in accommodating women in the workplace on menopause aren't the UN. It's not civil society organizations. It's not women's empowerment groups. It's actually private sector. It's private sector in the UK, in Australia, in the US now, catching up, and in Canada. That's where, and you know why? Because they, I wish I could say it's because that they're very concerned about women and their well-being. It makes sense. It makes good business sense. Private sector entities are pumping the pipeline, the management pipeline, full of young, bright women, supporting them, empowering them, sharpening them. And then at the age of 42, 45, they just marginalize themselves from the next promotion. They go and start a consultancy. And so businesses have realized that it makes good business sense to support these women through that short space time of their lives where they feel like they just can't cope. So I think that this is, for me, a great lesson for organizations to understand that it makes good business sense to support women at this time, of their lives. So as April said, normalize and respond, normalize menopause, the conversation around menopause, and respond. The issues that were discussed around vibrancy, around dignity, around reaching one's full potential in relation to menstrual health, 100% apply to a woman at this time of her life. A woman at this time of her life is at her peak. She has learned. She has equipped herself. She's now ready to lead, to give back, to mentor, and we should invest in her and make sure that she thrives through the menopause transition. Vidya.
I mean, there is so much that you've said here, and I know we're rushing because of time, and I promise you, we would organize another session, because we need to understand what is the medical field can propose, what is the traditional herbalist, can also provide support to. You mentioned about the way we clothes. I mean, the clothes that we wear, and we talked about cold drinks, all of these lifestyle changes, maybe exercise. I don't know. We know that menopause is also insomnia. So brain fog, we already mentioned, the psychologist, the psychiatrist, all those we didn't talk at all now, and we need to bring it because from the survey, we do not know. I mean, the answer, have you learned about it, read about it, talked about it to somebody? No, they don't know. They don't know what is happening to them. And this is an awakening for you and APA women and our partners online to learn a little bit more about their bodies and to fully understand what is going to go. And even perimenopause, we did not talk about that, which is another phase that is really, really embarrassing for women because of heavy bleeding. We didn't mention that. So I cannot thank you enough for scratching the surface of this conversation. And we didn't talk about menopause, andropause, and a lot of men are going through the same symptoms. So I promise you, this is the beginning. We're gonna continue. We promise ourselves 6 sessions on menopause, perimenopause, and others. And then we'll bring the men too to talk about men and sexual health, erectile dysfunction, Viagra, and all of those things. So thank you for what you've done today. And I know it will be followed with many other questions, and we will develop some briefs that definitely we will look to you to contribute into as we're looking to see what we can do for ourselves in our own organizations. There might be a few things that doesn't take much. And I love the fact that the private sector has been leading the way and can teach us good practices to really make women comfortable as they go through this transition in their life. So thank you very much, lady. It was a pleasure talking with you.
Vidya, just one last thing. Of all the things that we didn't say was that because we've got so many young people on this call, that there are lifestyle changes and mannerisms and habits that a young woman can pick up early on in life to lessen the impact, of the menopause years in her life. So just throwing that in there, the many things that we should talk about in future.
Absolutely.
And Sue, and on that note, there are things that we can do in perimenopause as preventative measures that reduce risks in postmenopause as well.
Yes.
So thank you for that, too.
Yes. Yes,
So
April.
thank you very much. I think they're gonna cut my mic if I don't give it back to the organizers.
Thank you, Vidya.
Thank you, Isaro, for
Thank
organizing
you.
this session. You could see how much we wanted to continue the conversation, but we thank you. Thank you for having us, all three of us. And over to the organizers. Thank you, thank you, thank you, thank you, April. Thank you, Sue.
Thank you.
As the previous speakers mentioned, the conversation doesn't end today. Thank you to all of today's speakers for your insightful contributions. As a young sexual reproductive health and rights advocate, I am truly inspired by the distance that we have come on menstrual health, and I look forward to contributing to the work that we still have ahead of us. Please don't forget to share your thoughts in the chat box and on social media also. Your voice really matters. As we close, we will watch the video by the Amaze Project and UNFPA on the variants of the menstrual health cycle. Once again, I am Lerato Lagamurulane Setlogolo Savarolong Khadia Satlana, and on behalf of the UNFPA East and Southern Africa and the African Coalition on Menstrual Health, it has been a privilege to host you. Kwaheri, goodbye.
First of all, you mark the first day of your period, which is when you start bleeding. Then you mark the first day of your next period. Then, wait, let me see. No, you count the number of days between the start of each period.
Why don't we just ask your sister? She's a peer educator.
I guess we can go and ask her.
Hey gang, how can I be of service today?
Hi, Nia.
We were wondering, is there a foolproof method of determining safe days?
Safe days, huh? You mean days when you're least likely to get pregnant?
If the stages of a menstrual cycle can be tracked, then surely there must be a foolproof way to know, right?
Well, Professor, it's a little bit more complicated than that when it comes to menstrual cycles. When someone gets their period, it can change from month to month and throughout their life, and it is not the same for everyone who menstruates. The menstrual cycle is a series of changes a woman's body goes through in preparation for a possible pregnancy. It begins with menstruation, which is considered day one of the cycle. Menstruation is the shedding of the lining of the uterus. It continues with an increase in the hormone estrogen, and the lining of the uterus becomes thick and spongy again. An egg is released from one of the ovaries, and it's called ovulation. The first day of menstruation to ovulation can be anywhere from 10 to 32 days long. It varies depending on the person's usual cycle length and the cycle. Then the egg is moved through the fallopian tube towards the uterus. If the egg is not fertilized within 24 hours, it disintegrates and is absorbed by the body. The levels of hormones such as estrogen and progesterone then drop, and usually after another 10 to 16 days, the next cycle begins and menstruation starts again. Fertilization of the egg, which leads to pregnancy, takes place after ovulation, the time when unprotected sex may potentially lead to pregnancy, also known as the fertile period, starts around 15 to 21 days before menstruation begins. Again, depending on the person and the cycle. This means that if you have a longer cycle, say 32 to 40 days, the fertile period will not be in the middle of your cycle, but later. And if you have a shorter cycle, say 21 days, the fertile period will be before the middle of your cycle. Many people talk about a 28-day cycle, but most people who menstruate actually do not have a 28-day cycle. Menstrual cycles can range anywhere from 21 to 40 days, but can be longer or shorter, and they can vary even more for young teens from around 21 to 50 days. Actually, during the first 2 years of menstruation, girls often have irregular cycles or miss periods completely, and this is totally normal. So are you confused? That is a bit understandable, and it gets back to the point that it is difficult and risky to try to identify what some people would call safe days. You know, days during their menstrual cycle when they think they cannot get pregnant. Young people who menstruate risk getting pregnant if they try to figure out their so-called safe days. And don't forget, there are no safe days when it comes to STIs and HIV. It's always best to use male or female condoms to protect against unintended pregnancy and STIs, including HIV. Other modern contraceptives will only protect against pregnancy, not STIs and HIV. Imagine, sperm can live for up to 5 days after sex. So especially for women with shorter cycles, it is possible to get pregnant during your period. Menstrual tracking apps, websites, and other digital tools have got better at predicting when your period will come, and they also provide information about menstruation and other topics. Knowing how long your cycle is and how much it varies can help you predict when your next period will come so you can be prepared. Whether you use an app, online tool, or a paper calendar and a pen or pencil, you can start by noting the day of your first period, and then the first day of your next one, and count the number of days in between. If you do this every month, after a while, you may begin to see a pattern of how many days in between your periods and how long your cycle usually is. You can also track how many days you bleed per month to know what to expect and to have the menstrual hygiene products that you will need. Remember, it is normal, especially for adolescents, to have irregular periods. That is, where the length in between periods and the length of days of bleeding varies greatly from month to month. All the more reason to get to know your own cycle.
Wow, Nia! Thanks for all this great information. I can see there is so much to learn about menstruation, and it is important that boys learn this stuff too. We all need to understand what boys and girls go through when we grow up and how to keep ourselves healthy.